To go.
Greetings, I'm Alan Lewis, and welcome to our Dean's Lecture Series on Culture, Lecture number 6, Health Disparities 101. Thank you for joining us today. So, as we get going today, just a few reminders. These sessions are in fact taped, and if you miss a session or if you know somebody who missed a session and would like to have the opportunity to view the session, they can certainly email my assistant, Franchon Jackson, and she can send the recording to them. Today we'll have, there's an article I wrote on disability disparities that might be of interest to you that you can also email Franchon if you want. The other thing to keep in mind is that we are trying to evaluate these sessions so we can make sure that as we go forward, they get better and they meet the needs of our customers, i.e. you. So please do the evaluations when Franchon sends them to you, and we greatly appreciate it. It's a very short set of questions. It'll take you 30 seconds to do it. So today, again, I said we're going to discuss Health Disparities 101. So last week, or I should say last month, these series of lectures happen monthly. We did Dean's Lecture number 5, where we touched briefly on the concept of health inequity and as it being differences in healthcare status due to modifiable factors. And so for all practical purposes, the concept of health inequity is pretty much equivalent to health disparity, which is the topic for today. So let's jump right into it. As you know, we do our typical 30-30 format, first 30 minutes, maybe a little less, me doing the talking, and then we have our conversation for the second 30. So when I think about health disparities, I tend to use the Institute of Medicine's definition that was articulated in 2003 in the book, Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare by Smedley, Nelson, and Stith. The Institute of Medicine commissioned that book, and so that's essentially their book and their position on health disparities. And that text says that a health disparity is a differential healthcare outcome based on race or ethnicity when factors such as affluence and access are controlled. Again, a health disparity is a differential healthcare outcome based on race and or ethnicity when factors such as affluence and access are controlled. So this raises an interesting point. If you had asked me what a health disparity was, say 30 years ago, when I was about 8 or 9 years into my professional career, and I had almost a decade of experience working in an urban public mental health system, I would have said that a health disparity would be, yes, those different outcomes based on race and ethnicity, but it was primarily due to differences in affluence, i.e. socioeconomic status, as well as lack of access by underserved populations. And so clearly factors such as socioeconomic status and lack of access, which we now sometimes call social determinants of health, they do negatively impact healthcare outcomes in underrepresented and minority racial and ethnic groups compared to European Americans. But the Institute of Medicine book made it exceedingly clear that such differences in healthcare outcomes due to race and ethnicity are still prominent, even when those social determinants, in other words, low socioeconomic status and inadequate access, are controlled for. So in the Institute of Medicine book, they actually share a plethora of studies, probably several hundred studies published in the decade between 1992 and 2002, where they cite these studies where differences in healthcare outcomes are documented due to race and ethnicity, where things like access and socioeconomic status, i.e. those social determinants, were actually controlled for. So in those several hundred studies, this determining factor in terms of the outcome being disparate was the race and ethnicity of the actual person receiving those services. And so this led to the Institute of Medicine's conclusion that healthcare disparities are primarily caused by bias at 2 levels: bias at the system level, inherent in the system, and bias at the provider level, either conscious bias or subconscious bias. And we know the providers have both. So it's not really an indictment of providers. It really does speak to the fact that providers need to be a lot more introspective and self-reflective to understand what their biases are and how they do in fact contraindicate effective services and get on top of those biases. So you might say, I understand the personal bias issue. It could be conscious or unconscious, but what do you mean, Alan, when you say bias at the system level? A couple of examples. I think in one of my previous lectures in this series, I talked about an event when I worked at the city of Richmond in Virginia, public mental health center, and we had an intake worker who was really taken aback this one day with this intake situation that unfolded. And here's what happened. In the public mental health system in Richmond at that time, and in most systems at that time, probably still today, when a person is going to access that system, there are certain rules around how the person accesses the system. And one of the rules is you show up to an intake appointment, and usually the person who has the identified problem and perhaps one other family member, and they sit and they answer a series of questions that the intake clinician would pose to them. So the intake clinician has a basic understanding of what's going on and knows how to refer that person to whatever area of the agency that needs to provide the services to that person. So it's usually an encounter that includes that intake clinician and the person with the identified problem, i.e. the client or patient, and maybe a support person for that person who's coming in with the identified problem. So on this particular day, that intake worker that we'll call Stephanie encountered a group of about 10 people who showed up in her office for a given intake appointment. And they all, she opened the door and she was surprised, and they all walked in her office. Her office wasn't that large, so couldn't really accommodate all those individuals. And she was like, well, what are all these people? Who are you? Why are you all here? And the group proceeded to explain to her that they were the family members, the immediate family of this person who had this potential mental health problem, and that in their culture, they all want to chime in and give their perspective on what's going on with this person. And so they all decided to show up for the appointment. So then Stephanie informs them that, well, the appointment is really designed for the person who's the identified client, and maybe one, perhaps two other people, or one or two people in addition to that person could be here. But they were adamant that they all had something to say about this situation, and they all stayed. And as it turns out, they were from a Latino background. I forget exactly what country they were from, but a country where in their culture, they're much more communal in how they deal with these situations. And their approach was that when this person needs help and they're going to access help through a formal system, i.e. the public mental health system on that day, they all had something to say about it. And so therein is the bias. The system was designed to address that situation with a set of rules that says that one person, i.e. the identified client, and maybe another person can show up, but not 10 people. And so the intake worker had to deal with that, but she was really taken aback and had a difficult time accommodating that situation, because on that day, the group that came in had a cultural norm about how they want to access the system, but it didn't line up with the rules of system entry that she was accustomed to in being the intake clinician. And so you can see there that the system, that mental health agency, actually had a set of rules around system entry that were the norm, but sometimes those rules get violated. So the bias is that that system really expected a person or two to show up at intake. So if more than that shows up, then there's difficulty dealing with that by the system. Here's another example. Years ago, I used to be director of the Virginia State Cancer Registry in the middle 1990s. And if you know anything about Virginia State Cancer Registries, they do surveillance and epidemiology to understand what the incidence and prevalence is and survival rates are for all the cancers. So cancer is a reportable disease that's required by the CDC that every state reports it. So cancer registries get those data from pathologists who do specimens and see cancer. They get them from hospitals, and they get them from private physicians. So they all have a responsibility to report to the central registry in their state when they have somebody who has a cancer. So as you might imagine, in certain instances, people who are affluent have the option of going to a high-end physician who may be able to be persuaded not to report that cancer to the registry, because when you report a cancer to the registry, one's demographic profile goes, a whole lot of personal information goes in addition to that fact that that person has a cancer of a certain type and a certain pathology, a certain stage. And so in most states, the cancer rate tends to be higher among persons of color because the reporting practice of pathologists, physicians, public health clinics really is influenced primarily by those persons who show up at those places, and they tend to be more underrepresented populations. And because most folks of color and don't have means, don't have the ability to go to a Beverly Hills doc and have that person to sort of bend the rules and not report their cancer. So you can see how the reporting of a disease in terms of epidemiology could be skewed based on who has access to the agencies that are doing the reporting, and certain people have access to other entities that should be reporting, but who may not be reporting 100% like they should. And the people who have access to those agencies tend to be people of means with high affluence. One more example, if you think about the Census Bureau, the Census Bureau does its every 10-year census, and a big part of how they do that is by doing household surveys. And they actually send people out, they do a survey, they send a survey, in some cases they send people out to go door to door and knock on doors and ask people questions about who's in their home. And we know that there's a difference in how forthright people are and what they disclose based on cultural orientation. So for example, a European American family, if you ask the question of, is there anybody in your home who has a disability or anybody in your home who has a chronic health condition, they may be very forthright in disclosing that. But we know that some other cultural groups, Latino American groups, some Native American groups, some African American groups are a lot more closed and less likely to disclose that information. So you see how the reporting gets skewed in the Census Bureau based on people's likelihood of disclosing that information, either on a survey or to somebody who shows up and knocks on their door from the Census Bureau. So the idea is that the public health, the health system, the mental health system in this country was primarily designed, years and years ago. And at that point, we had a population that was more homogeneous than it is today. And the primary folks who encountered and accessed that system years ago, say 50 years ago and more, were persons of European persuasion and primarily men. And so that system hasn't changed very much. And so now we have a much more multicultural population trying to access the system. And so the system has certain inherent biases because it was designed with one model of person sort of in mind. And now it's trying to accommodate all these other different types of people who are now accessing that system. And the system, although it's making some changes, it hasn't been comprehensively overhauled enough to really eliminate all the bias. So there's still some bias in our health systems. And so there's that system level bias that the Institute of Medicine talks about, and there's that individual bias that the provider actually has that may be conscious, but the provider may know that he or she has a bias, or maybe unconscious, or I shouldn't say unconscious, subconscious. And that person in that case would not be aware of the bias, but that bias could still be influencing the outcomes that person is having with the person they're providing services to. So the Institute of Medicine model for health disparities really is, I think, the prevailing model, and it's a clear model. And the reason I like it so much is because it is very clear that even though social determinants of health can exacerbate and make worse health disparities, it does say that even without those other factors, if you control for things like affluence and access to healthcare, you still have disparities in health status and healthcare based primarily on race and ethnicity due to the bias factors we just talked about. Since I do most of my scholarship in the realm of disability, which actually is a subsidiary of health, I developed a disparities model about 12 years ago, because at that time I didn't see a model in the literature that really spoke to the concept of disability disparities. Clearly there were health disparities models like this Institute of Medicine model that we just talked about, but there were no disability disparity models, no models that explicitly dealt with the concept of disability in terms of how the outcomes of disability services are impacted by race and ethnicity of persons who access those services. And so there is a difference when you may say, so what's the difference between disability and a health condition? Well, there is a difference. It's clear that every disability could be considered to be a health condition because there's some medical abnormality or some condition or I should say pathology that's involved in every disability. But every health condition doesn't rise to the level of being a disability because disability requires that there be no cure, that it's permanent, and that it has a major functional impact on a person's life, a negative functional impact. And clearly not every health condition does, but some health conditions do. Now, some health conditions that are chronic do rise to the level of being a disability because they are permanent, there's no cure, and they do have a negative functional impact on a person's life. But not every health condition can be called a disability, while every disability has an aspect of it that involves one's health condition. So that's a little bit of the distinction between those two. So now what I'm going to do is sort of share my screen if I can, so we can begin to look at this other model, which I will say, I call it a disability disparities model, but it is works both with health conditions as well as disabilities. Franchon, I see my screen says I'm disabled. It says I'm disabled from sharing my screen. Can you
Just fixed it.
fix it?
I just fixed it.
All right, thank you. So now, folks, let me just try to pull this thing up on the screen here. All right, I think you can see it now. So this is the Lewis Disability Disparities Model that was published in 2009, and it's available in the article that Franchon has. And the article is called Disability Disparities: A Beginning Model. And so it's in the Journal of Disability Rehab. And so, so we're going to take a few minutes and walk through this model and sort of learn how it applies to both disability, which is the reason I developed it, as well as to health disparities. So let's start off with the definition at the top. It's not an ideal visual because it's a page of the actual journal article, but I think we can work with it. So this is the informal definition of disability. A disability disparity exists when an underserved or ethnic minority cultural group's goal is to receive services within the formal rehabilitation and disability system, be it public or private, but there's a differential experience based primarily on cultural orientation that results in more incidents of disability and or lower participation levels in the formal helping system and or fewer successful individual outcomes when compared to the majority of cultural groups. So here in this definition, you see a couple of things. Unlike the Institute of Medicine's model, which really does speak to the outcomes, this model is a little more, this definition is a little more broad, and the model is as well because it talks about incidence and participation levels as well as outcomes. And it says that a disability disparity, meaning an uneven outcome, can occur in terms of both the occurrence of disability, meaning the incidence, as well as in the participation levels. In other words, how much people access and participate in the formal health system to address their disabilities challenges, and the outcome component. Now, implicit here, right off the bat, is a key assumption that we need to acknowledge. So this whole model is based on the assumption that we want the level of incidence and the participation levels and the outcomes in underserved minority ethnic groups to be on par with that of European Americans, the majority group. So the comparison here is the white population, the majority population in our country. And the point is that whenever we see that other groups, minority groups, underserved populations don't compare or are not on par with the dominant white European American population, then there's a problem. So that becomes the comparison. Now you may take issue with that, but that really is the assumption that this model is based on, that we should see some parity across groups in terms of these factors such as incidence, participation, and outcomes. Because if you see the parity, then you see that at least people are accessing and experiencing things on a comparable level. And it's not, if it's bad for everybody, then that's a problem for the whole system. But what we're seeing with these disparities is that it's primarily much worse for persons of color and compared to their white counterparts. So that's the primary comparison in this model. So this model may look busy. So that's the definition at the top. Let me try to orient you to it. It's got a couple things in it. So the very top, you see on the left side, moving left to right, you see some domains. And what it says is hypothesized view of what accounts for differential experiences. So across the top, you've got the reasons that are hypothesized, my hunches around what accounts for these disparities in each of these domains. So this model is based on a continuum. It's 5 domains, and it goes from domain 1, so move down to the blue area where I say macro level. And I can show you what oh yeah, right here, I got the pointer here, macro level. So first we're talking about the hypothesized view of what accounts for differential experiences. And these are the things here. And we'll get into these in just a minute, just kind of giving you a broad overview. And at the top, you see domain 1, 2, 3, 4, and 5. So let's draw our attention first to this level, because this level is the macro level, and this is where the clarity of the concept for each of these domains is articulated. So domain 1 talks about factors that account for high incidence. So the issue here is incidence, or the occurrence of disability in this whole first domain. Domain 2 talks about the group's perspective on disability as system engagement is contemplated. So the idea here is that groups that are persons of color and culturally diverse groups don't always, like European Americans typically do, embrace the idea of engaging with a formal system for their problems, because they have a lot of indigenous and other informal supports that may be useful to them that they may want to access before they go down to public health clinic or the local mental health clinic. So the second domain really deals with what I call a process of contemplating engagement, which is the beginning of participation. So participation occurs first with contemplation, thinking about whether one's going to actually engage. And then domain 3 is access to the formal system. So this is still participation, but this really speaks to whether or not that family, as in the example I told you with the intake person in Richmond, is actually going to access that system, how they want to access it based on their help-seeking traditions within their own culture. Domain 4 is the nature and the quality of service. So at this point, we're assuming the person with a disability has actually accessed the system and is engaged in the system in some way, receiving services. So it's the nature and quality of the service experience and beginning outcomes. And then domain 5 would be the actual impact of the services in terms of what the individual benefit or outcome is on that person after they've had a high enough dose of the system services. So let's get oriented again. This blue level, or these blue circles, really are the concepts that comprise this model. And you'll see the model is progressive. It goes from the occurrence of disability, meaning incidents, to one considering accessing the system to get help for the disability, what I call the contemplation process around engagement, to actually accessing the system if the person decides to access the system, to actually what that level of participation is once the person is engaged in services in the system, and whether they're achieving a high enough dose to actually expect to see an actual positive outcome, and then the overall impact, bottom line outcome of the service encounter in the healthcare system or disability system in this case for that person. So it's sort of a progressive model that moves from the occurrence of disability to thinking about getting help through the formal system, to actually accessing the formal system, to actually participating in the formal system to some level or not, and what outcome they may achieve. Okay, so this macro level really it provides hopefully some clarity of what these 5 domains really are all about conceptually. All right, so let's go back up to the top, to this red area, and where it says hypothesized view of what accounts for differential experiences. Okay, so for domain 1, the things that I think impact differences we see in incidents in minority groups and underrepresented populations versus the majority group are things like cultural and biogenetic traditions. In other words, the group's intergenerational response to oppression, poverty, and social stress. And we'll drill down at the micro level to see what that really means. But this is just a concept up here. Okay, so domain 2 has another hypothesized reason why a group may contemplate engagement rather than just automatically embracing accessing the system. And that is the ethnocentric worldview, or the inability of service systems to embrace pluralistic viewpoints and values. And what I mean by that is sort of the bias piece again, that most systems were designed for a fairly narrow population of persons to access them, primarily white males in this country 50 years ago and before. And most systems are not elastic enough to really effectively embrace all the differences that they're dealing with now in terms of all these multicultural populations that are actually showing up for services at the doors of these systems. So this same reason I think also impacts domain 3, which is the access process, the extent to which the person actually accesses the formal system. So I think this ethnocentric worldview and the inability of systems to embrace pluralistic viewpoints and values, i.e. the bias in the system, impacts both the group's engagement in terms as they contemplate the group's contemplation rather about the engagement, as well as the access process they go through if they're going to access the system. And then you go to another reason, which actually I think influences the 4th and 5th domain, which is practitioners and service system bias, conscious and unconscious values that contraindicate serving diverse populations well. So primarily here we're talking about practitioner bias, a little bit of system bias as well, but primarily the fact that the providers who provide disability services or health services have their own personal biases that may be conscious or subconscious, as I mentioned earlier, will impact both the nature of the quality of the service experience. In other words, what the person is getting when he or she is actually in the system and what dose they're getting, as well as the impact in domain 5. Okay, so down at the micro level is where you begin to see a little more specificity about what we're really talking about here. So for this first domain, remember we're talking about incidents, the occurrence of disability. So the micro level is really designed to begin to provide sort of a menu of options or menu of topics that a practitioner who's working with a client can actually consider for their own exploration if they believe the person is actually having a disability disparity in domain 1 related to incidence. In other words, the incidence within the group of whatever the ailment or disability is higher in that cultural group than it is in the majority population, i.e. the white population. So for this first domain, again, we're talking incidence. So the things that will be considered by a practitioner at the micro level, a clinician, an individual healthcare provider, would be these things in this yellow sphere. Keeping in mind, we're talking about cultural and biogenetic traditions and the group's intergenerational response to oppression, poverty, and social stress that will speak to whether or not they have a higher incidence of a given disability or health condition compared to the white population. So here are the things that we're talking, drilling down now, the things we're really talking about are lifestyle considerations such as risk-taking behavior. You find that in some communities of color, people take drugs and do some drinking and engage in things to sort of as a stress release. Also risk-taking behavior, I think I just said high risk and stress environment, self-medication to cope with, as in substance abuse, as I just said, and then factors related to metabolic syndrome, which are really lifestyle factors. Things have to do with obesity, the extent to which people have high blood pressure and diabetes, and those things that together can increase one's likelihood of actually having a stroke or heart attack. So primarily here, what the clinician would explore would be the lifestyle considerations in their client to see to what extent those considerations may actually be precipitating the higher incidence that they're seeing of the disability or the health condition in the group that this person belongs to, the cultural group this person belongs to. So again, it's the group's intergenerational response to oppression, poverty, and social stress that really is what I hypothesize that leads to the higher incidence, if that is what you see. This is just the concept of higher incidence, and here are the lifestyle considerations that a clinician can actually look at and consider in working with a particular individual to understand the extent to which that person may be having a domain 1 disability disparity and what the clinician can certainly positively impact to improve that situation. Okay, moving along to continue to domain 2 again. So this is incidence here. So it's domain 1. Domain 2 really is group's perspective on disability as systems engagement is contemplated. In other words, what is the cultural group, the Latino American group, the Mexican American group, whatever the group is, the person's cultural or primary cultural identity is, what do they think of system engagement with the formal system? And so that's the concept. And then here again, we're drilling down to things that a clinician can actually ask questions about if they think the person is dealing with a disability disparity that relates to the contemplation about the engagement process. The first piece would be the group's view of etiology or the origin of disability. So depending on how the group views the reason the person has this disability will determine what they think the actual solution is. Sometimes groups think that disability has to do with divine intervention or some supernatural force or some punishment for some sin or something that happened in a previous generation. We see that some in the Native American cultures. And so if they think that the origin of the disability is something supernatural or divine, they're probably not going to think that accessing a mental health clinic or a disability service system is going to resolve that. So that determines that's a big part of that contemplation process, what their view of the etiology or origin of that particular disability, disabling condition may be. Also, in addition to that, the group's view of typical disability progression with and without intervention. So not only is it the origin of disability that's important, they also look at whether the group has this perspective of that the disability will get better on its own, or does the disability require some actual intervention from a formal system to actually make it better. Again, this is the disability disparities model, but we can insert the word health condition for everywhere we have. Every time I say disability, you can think health because it still works, I think. And then the other third factor here is the group's view of the type of intervention that will be efficacious. So sometimes groups that are minority and underserved and non-white cultural groups view interventions as being efficacious as being things like faith-based interventions or community medicine man or medicine woman or community shaman type intervention. And so more indigenous strategies rather than Western medicine type strategies. So this whole bubble here for domain 2, we're talking about the process of the group or the person in that group contemplating whether they're going to actually access the system, which would be participation, focuses on what they view the origin of disability is in a cultural group, what the group feels like is the typical progression of a disability or health condition with and without intervention, and then what the group feels is the type of intervention that actually will work. So if they feel like that we're talking to the community or village medicine person or going to the church or the minister is really what's going to work, that's what they're going to do. They're not going to access the formal system. So you have to ask these kinds of questions when you're working with a particular person if you believe that they're dealing with a domain 2 type of disability disparity, which would be a disparity related to whether or not they're going to engage with the formal system. So a contemplation process. Domain 3, we're talking about actually accessing the formal system. So if the person's actually here in domain 3, then the decision was made here in the previous domain to actually access the formal system for help. And so now we're talking more about the factors that will determine how they actually access the system. In other words, will they be successful in accessing the system? And what does the system say about rules for entry? Remember the intake situation I described earlier. And what is the group's cultural way of accessing the system in terms of those rules? So here's the role of socioeconomic status and access. So sometimes the person needs health insurance. So if the person is lacking affluence or is living at the poverty level, they may not have the health insurance, meaning they have a low socioeconomic status and the health insurance is not there for them to actually access the system because some systems require payment of some sort, even if it's on a sliding scale. So that's one factor to consider. The other factor is the group's culturally driven help-seeking tradition. So some groups are very much not inclined to access the formal system based on historical issues and issues of trust and things that have happened in the past. And so sometimes they will, sometimes they won't. And then it's the how do they seek that help? Going back to my old intake example, this group, that family sought help in a group manner. They did not fit into that individual person showing up who has the problem and specifying what their problem is. They had a more communal group model where they all want to show up. So their culturally driven help-seeking tradition was that we all speak on this, not just the one person who has the identified problem. And then it gets down to what's the interaction between the rules of system entry. In other words, what does the system say you have to do to enter? And what are those rules? And how that interacts with the group's help-seeking tradition. So the system rules versus the group's help-seeking tradition. On that day with Stephanie, when I described the intake process in mental health years ago, the interaction was that they ultimately were able to use their own communal group help-seeking strategy, but it certainly did overwhelm Stephanie, the intake clinician, but they did ultimately work it out. It could have been a situation where she was not willing to deal with them because there was too many of them and she could have just shut the whole encounter down. And maybe that family and that person who needed the help might not have accessed the system. Okay, domain 4, nature and quality of the service experience. So at this point, they've accessed the system, the formal system here in domain 3. Now they're in the system and the services have actually begun. And so the question is, what's the nature and quality of the service experience? In other words, is the participation going to be adequate and appropriate and of a high enough dose to expect to see a change? So the kinds of macro level considerations are, what's the strength of the treatment of the alliance between the client and the provider? In other words, how much trust does exist between the client and does the client trust his provider, and whether they have a good therapeutic alliance and good rapport, a good therapeutic relationship. That will determine whether or not the person will be there enough to actually receive a high enough dose, the critical threshold of dose needed to actually expect to get better. It also depends on factors related to the provider's ability to meet the client's cultural expectations. So this really gets to whether or not the client or the patient or the service recipient thinks that their provider, their clinician, is culturally competent or culturally sensitive. So here, it really depends on the provider's skill and their ability to identify and be viewed as a culturally sensitive or culturally competent person. And then it gets down to how much engagement there actually is. In other words, how much of the service does a person actually avail her or himself of, which is really a dose consideration. Because obviously, if it's a service where a person's supposed to be there, 3 days a week for 6 weeks to achieve enough dose, and they only come once every other week, then that's not going to be a high enough dosage to expect to have an actual outcome. So for this fourth domain here, which is the nature and quality of service experience, the concept, And we're still talking, here we're talking about bias, primarily at the practitioner level with some service system bias that accounts for this issue. And so what will overcome this is if there's a good therapeutic alliance between the client and provider, in other words, trust. If the provider is able to meet the client's cultural expectations and that client views the provider as being culturally sensitive, and if that client can have enough engagement to achieve an adequate dosage of the services. Again, these things in yellow are micro level aspects practitioners can actually explore. And then over here on the fifth domain, which this domain really is the most important domain because it's the bottom line end of the process. So I shouldn't say most important, it is sort of the end of the process kind of domain. And it talks about the impact of the rehab services if you're talking about a person with a disability or disability services, but it could be any health care delivery service that's been provided, and whether or not that impact has provided individual benefit, some positive outcome. And here, the clinician wants to make sure that they address the extent that the outcomes actually align with the person's cultural orientation. In other words, everybody has an expectation around the outcomes that she or he wants to achieve through services, and sometimes those expectations differ dramatically based on a person's cultural orientation. And you can't just assume that if the outcome was achieved that the clinician thought was appropriate, then that's successful. It has to be the outcomes aligned with the cultural orientation that the person who is the service recipient has. Outcomes must also be adjusted for different beginning severity levels. Oftentimes we don't remember to do this. We don't remember to adjust outcomes for where the person started in the process. Over here, if a person came in with stage 4 breast cancer, then the outcome may be different than a person who's coming in with a stage 2 breast cancer. And so you've got to make sure that as you measure the outcomes and make sense of these outcomes, that you've adjusted for the beginning severity level, what that person's severity of illness was, or severity of disability, what the functional limitations were, and how severe were they at the beginning of the service delivery process. And then you have to make sure those outcomes are measured, not just with objective measures, which we love to use, but also with subjective indicators, things that really speak to whether or not that person feels satisfied with how the service encounter and the service delivery process played out. So that's essentially the model. So in summary, let me just say that this is the definition up here, which spoke to the assumption that the whole model is based on making sure that there's some parity across different cultural groups with what the dominant population, i.e. the European American or white population, experiences in our country in the healthcare or disability system. And we're talking about incidence, participation levels, and outcomes, not just outcomes. And then in this model, you have 5 domains. So it's a progressive model from the incidence of the disability all the way to the actual outcome and some steps in between. At this level, we're talking about some hypothesized reasons or hunches that could account for differential experiences across these 5 domains. Here we're talking about the actual domains, what they mean in concept. This is the conceptual clarity. We're talking about incidence here. We're talking about contemplation of whether to engage with the formal system. We're talking about accessing the formal system. We're talking about the nature and quality of the service experience once it's in the system and the actual outcomes. And then at the bottom, we have several, have all 5 domains again. And these things listed in these yellow bubbles really are some factors, not exhaustive, but some factors that a clinician at the micro level, i.e. a practitioner, can explore that relates to each of these domains. So that's the beginning disability disparities model that I published back in about 12 years ago, 2009. And this diagram is part of an entire article. If you want to read more about it, certainly Fran Chong can make that available to you. And now the big thing I want to say about this model is that it was designed because there was no model in the literature that explicitly dealt with disability concerns. But I do think when you look at the model, it's easy to see that it applies not only to disabilities, but also health conditions, because these factors of incidence, system contemplation about system engagement, access, nature and quality of the service experience, and the impact of services in terms of the individual who received them, those are pretty generic and can apply to whether the person is receiving services for a disability or any health condition. And so these concepts can go either way, disability or health condition. So with that, let me stop and I'll talk to you on the other side when we start our discussion format.